Hello everyone. Let's talk about hemolysis today. Whenever we receive a call from the emergency department or from another ward that the patient has low hemoglobin and there is a sudden drop in the hemoglobin, um, hemolysis come in our mind as a differential diagnosis as well. Um, How do we pick hemolysis on investigation? It is the MCV, which is usually high LDH, abnormal liver function test, and the blood film. The blood film tell us whether there are any spherocytes, macrocytes, polychromasia or not. The problem here with the hemolysis is that it is not always autoimmune hemolysis. There are very there are many different causes of hemolysis. So we need to keep in mind the different causes of hemolysis. We need to take history from the um, referring team that is contacting us regarding the patient. Ask them if there is any infection, what is the hematinic level in this patient, is there any a history of autoimmune disease in them or not, recent transfusion or any um, previous history of enzymopathies or membranopathies, because the list of hemolysis differential is quite long. Do not jump to that testing all of a sudden that you do not need to do that test in all of the hemolysis patients. Yes, if you have excluded other causes of hemolysis, then the last option is autoimmune hemolytic anemia. Then you will go for that testing in your patient. So now the main discussion is about autoimmune hemolytic anemia. If your DAT test is positive, then the blood usually goes to reference lab to test it further to see for any underlying antibodies in this patient. This process usually takes 3 to 4 hours depending upon your distance from the RCI lab, because transport also take time and the workload also take time as well. In Yorkshire, in my setup, it usually 3 to 4 hours when the sample goes to RCI lab and then come back. And this much time is usually taken by the processing of the blood for extra investigation. So the major mistake that the people do in their consultation or especially in the exam when they are advising regarding autoimmune hemolytic anemia, they mention steroid to the team, but they forget to mention the supportive treatment along with the steroids. Because hemolysis is a very prothrombotic condition. Uh, if you do not give them VTE prophylaxis, uh, um, there is a high likely chance that the patient will develop thrombosis. So, VTE prophylaxis is must. People usually forget that in their consultation with the other people. And the second thing is that this patient is actively hemolyzing. Folic acid is important. You need to replace the folic acid in this patient as well, which is necessary for the buildup of the new red cell. With steroid, do not forget vitamin D and calcium replacement to protect the patient from osteoporosis and PPIs. Many such incidents has happened where patient is receiving high doses of steroid, 1 milligram per kg of steroid without PPIs, and the patient develop GI bleed. So this is the main complication of the steroid. You may be practicing that, but sometimes during the exam stress and during consultation, we are multi-tasking sometimes, and we forget this thing to mention to the referring team. So better not to miss that. And when you remind when it is reminded to you that you have given someone um, advice regarding steroid for the autoimmune hemolytic anemia. Double check your documentation, or double check their documentation whether they have written PPIs for the patient or not. Yes, the autoimmune hemolytic anemia causes are multiple. They can be primary or they can be secondary as well. And the commonest secondary causes of autoimmune hemolytic anemia in UK is the viral infections, ABV, CMVs, and other infections. And then obviously we are from hematology. There are multiple hematological causes of secondary autoimmune hemolytic anemia as well, most commonly lymphoproliferative disorder. Blood film will tell you whether you are dealing with infection or with possible lymphoproliferative disorder. Any patient with a recent transplant, they are also at risk of developing uh, autoimmune hemolytic anemia as well. This is one of the common causes of anemia in post transplant setting. So, whenever you are advising for autoimmune hemolytic anemia, do not forget supportive therapy for the patient. Then, um, during part one hematology and part two hematology sessions, some of the people say that our trust do not transfuse patient of autoimmune hemolytic anemia because they will develop hyperviscosity and they can develop clot. So this is trust to trust variation in the policy. My trust says that if the patient has low hemoglobin and symptomatic, then this patient needs blood transfusion. Symptomatic means if the patient has chest discomfort, um, dyspnea on talking, um, cannot walk because of the dyspnea, then you need to transfuse this patient because this patient may develop type 2 MI after some time because patient is actively hemolyzing. You are giving steroid, and steroid may take time to show its effect. In such cases, we always give them IVIG as well because IVIG shows its effect quickly than the steroid. So I think do not wait for the worst that the patient develop full-blown MI because of the anemia. If the patient is symptomatic, like having chest pain, give them high doses of steroid in the form of methylprednisolone plus IVIG. The guidelines have also mentioned plasma exchanges for symptomatic autoimmune hemolytic anemia, but it is case by case based and depends on your trust and consultant as well, whether they want to um, give this patient plasma exchange or not. Usually, those patients who are refractory to IVIG and methylprednisolone, then we give them plasma exchange, but it is very rare. So, when I was checking the papers for autoimmune hemolytic anemia in the mock exam and in the session, yes, many people mentioned we will give this patient steroid because this is DAP positive autoimmune hemolytic anemia. But then they did not mention PPIs or folic acid or vitamin D and calcium. I would say this is a blunder. Uh, this thing may cause problem to you in practical life, or it may cause a failure in the essay section or in the exam, Parsifat exam as well. Because steroid without PPIs can lead to gastric complications, bleeding, and it can be um, worse complications sometimes as well because it lead to gastric ulceration and bleeding, and the bleeding can be severe as well. So please do not forget supportive treatment with the steroid in autoimmune hemolytic anemia. It may cause serious problem for you and for the patient as well. We will be discussing topics like this from our routine life. For the Overseas candidate, they may be asking what is RCI. These are the NHSBT regional labs which do higher level of testing on blood when they are dead positive. They do adsorption studies, elution studies on the patient. They are not done in the local blood transfusion lab. RCI is called red cell immuno. Um, I think it's immunohistochemistry lab. Um, I assume. I also forget the actual term now, but in short term, it is called RCI. Let me double check the true term for the RCI, whether it is uh, so red cell immunohematology lab, not a red cell immunohistochemistry. Sorry about that. We always use the term RCI, but sometimes we forget the explanative term as well. So the main point of this discussion is that when you are dealing with autoimmune hemolytic anemia in an exam setting and in your practice setting, do not forget the supportive medications. They are equally important as steroid. We'll see you next time with another set of discussion about our daily calls. Um, I would say if you have Boko app, use Boko app. It helps you a lot in dealing with the day-to-day calls in the registrar life. Uh, for my part one group people, I have posted there as well. Boko app, BUKU app. And when I was ST3, ST4, I used this app a lot. Even still, I'm using it. Whenever someone called me that my patient platelet is low, platelet is high, pancytopenia, what workup should we do? Lymphadenopathy, what workup should we do? Or patient has splenomegaly, what workup should we do? So I would say use Boko app. It is very interesting and save you a lot of your time and anxiety as well. And we will be in touch with you for such discussions. Thank you.